on the board for Torch. So good morning again. And Shelly Young is our next speaker, and she's the program manager for the Alzheimer's Association, the North Central Texas chapter, where she served for 18 years. Ms. Young has a Master of Science in Gerontology from Abilene Christian University and has worked with seniors for 30 years. Much of her employment has been in the senior care industry, including assisted living, nursing facilities, and home care. During this time, she's had the privilege of working with many senior adults and their families as they try to find appropriate services and make the difficult choices that families often face. Ms. Young's mother suffered from Alzheimer's disease for over 10 years. Her mother passed away after living in a nursing facility for 3 years, and her father suffered from Lewy body dementia and lived in a care facility also for 6 years. So Shelly will be presenting on rethinking engagement for today's older adult. So let's give her a welcome. Thank you.
Beth, thank you so much. Are you hearing me well enough? I will probably do this, and you'll have to remind me. But I hate microphones. I think most people do, but I do try to use them properly. So Hannah, wherever Hannah, okay. So we were going to hand these out. This is just a little supplement to my presentation. We can hand them around, but this is a rack card from the Alzheimer's Association. And it has some of what I'll talk about today, which is the warning signs or basically symptoms of Alzheimer's and related dementias. But I like this card because then on the back, it also gives you our 24/7 helpline number and our web address. And so there's lots of good information on there that you may want to follow up with at a later time, because we obviously don't have time to cover everything today. So I suspect a lot of you in this room have heard some of what I'll be talking about today. And so hopefully it won't all be repeat. Hopefully you'll learn some new things along the way. And it's interesting because as long as I've worked in really kind of senior care and long-term care, there's still so much confusion just even about the basic language that we use around dementia. Still the single most commonly asked question I get is what's the difference in Alzheimer's and dementia? And so hopefully I'll be able to clear that up for you and help you to better communicate too with the people that you're serving, including your employees. So tell me a little bit about who I have in this room. So are all of you working in actual specific facilities, or are you some more in like management of multiple? Kind of give me an understanding of your experience and where you are. Anybody?
Owner operator.
Okay. Yeah, I know you. I see you at meetings. Yeah. Who else?
Director.
Okay. Yeah. So tell me, how many people do you think in the properties where you work, how many people do you think have dementia of some sort?
90%.
Yeah. I think a lot. I think that's probably true. And even, independent living, which is really not meant for people with dementia, but independent living has pretty high percent, I think, depending on where it is. And, people are just contracting to get services in. And it's really hard, like dementia, even though there's so much we know about it, there's a lot that we can, put on paper and talk about a lot of commonality, but it's so specific and unique to the individual, but also even to their family. I think the family dynamic plays into how well these individuals fare for the long term. Sadly, finances play a huge part in how well they do, because if you can't pay for good services, then you're going to struggle a whole lot more on this journey. And then even where they live, their setting can be incredibly supportive and helpful to them, or it can be incredibly frustrating to them and to their families, and then those of you in this room. So let's just dive in right now. So first of all, I want to just give you a little bit of information. So the Alzheimer's Association is a national organization. We were actually founded in 1980. And so we've really been at the forefront of dementia care research and advocacy for a long time. But one of the things I love about our organization is that our founder was a guy named Jerome Stone, and his wife had Alzheimer's. And back in the 70s is when he would have been caring for her. And he was just finding that, back then we were just barely starting to even hear the word Alzheimer's. and even to get a tiny bit of understanding, but he recognized that what he was doing was really hard. And there wasn't a lot of support. And so through kind of these informal support systems that he created for himself and people in his community, now we have the Alzheimer's Association. And so I'm really proud of the fact that we started as caregiver support. And that's where I get to spend my time every day, is really helping those who are out in the community doing the hard work, including you. I mean, you may not be the one going in necessarily and changing the pens or helping with dental care, but you're in the trenches too. So again, we've been around for a long time, and I'd like to start with this also because we're here to help people no matter what type of dementia they may have. Don't let the name fool you. There are many different types of dementia out there, and we're just here to support individuals on this journey. And in some cases, the people we serve never get a diagnosis. Sadly, it's not as straightforward as we would like it to be. And in some cases, too, physicians will just say, oh, it's old age, or families are afraid to take their loved one in and hear what the doctor has to say. So just know we're here to help. And we do not require a person to have a diagnosis of Alzheimer's before we can help them. So the Alzheimer's Association leads the way to end Alzheimer's and all other dementia by accelerating global research, driving risk reduction and early detection, and maximizing quality care and support. So we are also the largest private funder of Alzheimer's research in the US. We convene the largest Alzheimer's conference each year, usually in July, and it is an international conference. I believe in July of this year, 2025, I think over 11,000 people participated in the Alzheimer's Association International Conference. But I love the stuff that we get to do that's local, that's in communities. And so one of the things that we have embraced more recently, we don't know what causes Alzheimer's. We can't legitimately say that we can prevent Alzheimer's or other dementias, but we know there's a lot of good information out there that supports that a healthy lifestyle is going to help us fare better for the long term. So even if we can't say prevent Alzheimer's, we may be able to delay the onset of cognitive decline. So we really want to help folks engage in healthy lifestyles. And that is bigger than just exercising and eating right, because all of us struggle with that. I mean, I hate exercise. I'm just gonna be honest with y'all. The last thing I want to do when I get up in the morning is go exercise. Doesn't mean that I shouldn't, but it's not my favorite thing. But there are other aspects of brain health, not just exercise and nutrition. But then we also want to encourage, even within medical communities, early detection, because the treatments that we have are more effective the earlier they're started. And then we want to, for people who are already on this journey, firmly planted in this Alzheimer's journey, we want to support them. And so we provide education, support groups, care consultations to those individuals. So some of that we'll cover kind of as we go along, but that's who we are. So this is why I get up and do what I do every day. This is mom and dad. My mom was on this journey, as Beth mentioned, for over 10 years. And of course, we even know now that the scientists, researchers believe that Alzheimer's is starting in the brain. Those brain changes start occurring 15, maybe 20 years before the onset of symptoms. So we're only really treating it when the symptoms have started. And so again, part of what we know is, what if we could back it up? What if we could do some things earlier that will help promote brain health? And then there's my dad. And I like this photograph too, because I think it's helpful in that if you look at my parents, you don't see dementia. If you had walked past my mom, who was living in a nursing home at the time that this photograph was taken, she was not verbal. Well, actually, she made noise. She didn't make sense. She was jabbering. She was probably 8 or 9 years into her Alzheimer's journey in this picture. And then my dad was living independently, still driving, going to church multiple times a week, volunteering, going out with friends. But his dementia had also started. I shouldn't say that. Those changes were occurring in his brain. You just can't see them. And so I think it's really kind of deceptive, even especially for families. They look at their loved ones and they look okay. They don't look sick, but literally parts of their brains are dying. And so I think it's helpful for people to understand that even if we can't actually see those changes, something is going on. So here are some current stats. I'm not going to read all these to you, but we know right now over 7 million people in the US have Alzheimer's disease. I think most recently about 7.2 million. This stat right here in the top corner, I think is really telling. So Alzheimer's disease kills more people every year than breast cancer and prostate cancer combined. And I think that's surprising to most people. It was surprising to me. But think about it. We hear a lot more about cancer. And we've also, as a country, we put a lot of money into research. And so we have better diagnostic tools and better treatments than what we did in the past. So people aren't as frequently dying from these cancers as they used to. And so there's a great hope in the Alzheimer's world that if we do the same with Alzheimer's, we're going to see a return on our investment. Also think this one, the purple one, is really telling. In 2025, Alzheimer's and other dementias will cost the nation $384 billion. That's a lot of money. I'd rather be spending that on a European vacation than caring for someone who has an awful, awful disease. Let's see, what else should I share? Oh, 92% of Americans would want a medication to slow the progression of Alzheimer's following a diagnosis. And we're already there and really close to it. And I'll talk about that a little bit more. So I think most of you in this room probably know this already, but there are some things out there that can actually cause memory loss or confusion that aren't dementia. We know that people who are malnourished or maybe even dehydrated can act in ways that are out of the norm. And so that actually happened with my aunt who did have dementia. She was my mom's sister, and I believe she also had Alzheimer's. But there was a spell where she ended up going to the hospital, and what they figured out was that she wasn't taking her medication properly. She wasn't eating as well as she should have. And I mean, she was living with my uncle. He was seeing her eat, but what he didn't realize is she wasn't really capable of adequately hydrating and taking in what she needed. And so they took her, she ended up in the hospital for a few days, and she got a lot better and her cognition improved. The dementia didn't go away, but they treated the things that needed to be treated and could be treated. And we still saw improvement in her cognition and her mental clarity. We know things like excessive alcohol use or abuse, I should say, can cause a person to have memory loss and confusion. Even things like really severe depression or grief. You know, you may see this more in a person who has recently experienced just a severe or traumatic loss. So there are many different things that can cause these cognitive problems. And then, of course, who in here knows about the impact of a urinary tract infection on an older person? You know, I had a lady when I worked in housing, and she lovely little lady, and she just got up. She was just acting weird. Now, she wasn't being combative or agitated. She didn't even have dementia, but she was doing things that were out of the norm for her. And thankfully, staff recognized it, and the family took her to the doctor. And within a couple of days, she was back to normal. So all of these things can cause confusion. They can also then overlap or lay on top of dementia and cause people to even be worse than they would with their dementia. So then the last thing that causes cognitive problems is disease or things that are permanent. So again, I mentioned earlier the most commonly asked question I get is, what's the difference in Alzheimer's and dementia? And so what I'm gonna jump forward and then we'll go back. So I like this graphic. I think it helps people understand that dementia is actually the umbrella term. Dementia is a condition. I've heard it referred to as a syndrome. And dementia is a condition that often people who have dementia will experience things like memory loss, challenges with other thinking abilities, difficulty with reasoning and judgment, difficulty with communication, and these are severe enough to interfere with daily life. And these are some of the things that cause dementia. Alzheimer's is the most common cause or common type of dementia. And so the estimates are still that around, I think 60 to 70% of people have Alzheimer's disease that have dementia. And so it is the most common. That's why you hear so much about it. But we know there are other things that can cause dementia. In fact, there are probably upwards of 100 different illnesses that can cause dementia. These are just the ones that we really know about, that we hear more about, and that there's been more research into vascular dementia. I suspect that a lot of you in this room have cared for people who have vascular dementia, and that's caused by strokes. And so that one looks, generally it looks a lot like Alzheimer's, I think, but the difference that you may see is that depending on where the stroke occurs in the brain, then that may have a direct impact on that person's ability to function. So for instance, if it happens in a part of the brain that has some control over language and communication, then you're going to see changes there. So the path can look a little different with vascular dementia, but it looks a lot like Alzheimer's, I think. Another thing about vascular dementia is that it may appear more like a stair step. And so a person with vascular dementia may float along for a while doing really well, and then they have a stroke, and there's a dip, and then they level out again. Whereas with Alzheimer's, it tends to be a more gradual progression, but there can be a lot of variability even within these. Certainly Lewy body dementia, that's the type that my dad had, and that is also the type that Robin Williams had, the actor Robin Williams. And it came out after he committed suicide, sadly, that's what he was struggling with. And so it was impacting, I think, particularly things like he was having some vivid hallucinations. Lewy body can also have a real impact on a person's sleep and other abilities to function. I know a guy right now, he's in one of our clients, and he also reports a lot of depression with his Lewy body dementia. Frontotemporal dementia is the type that Bruce Willis has. And so that's been in the news a lot, which, I mean, that's good and bad. It's certainly sad for him and for his family, but it's brought attention to the dementia world and to what we sometimes refer to as FTD. And that one tends to impact the frontal lobes of the brain. And so the person with FTD may have more trouble with reasoning and judgment. They may do things that are socially inappropriate, not recognizing that what they're saying and doing is not okay. I've even heard of people with FTD and honestly other dementias that maybe shoplift because they don't recognize, they don't understand that what's in that bin at CVS is not theirs, that it belongs to someone else. Also, like with Bruce Willis, I think that with the FTD, he's had a lot of trouble with language, and you can imagine that that's incredibly difficult for an actor. And he made his living by being a communicator and a good communicator, and now it's very difficult for him. So you can see how all of these differ and have their own hallmarks, and they're all different diseases. They're all different things happening in the brain, but the outcome is over time very much the same. Does that make sense? Yeah. Okay. So I'll back up for just a second. So the definition of dementia, this is a little more in depth than the other one I shared. Dementia is a general term for loss of memory, language, problem solving, and other thinking abilities that are severe enough to interfere with daily life. But I want to add a piece to this. So when these things start to happen, that's when we see changes in behavior. And behavior is one of the hardest things that I think that we deal with in our loved ones or our clients who have dementia, because they act in ways that we don't understand and that can be really challenging to deal with. And so I think it's important to understand that these things are not just standalone, but they lead to changes in behavior. So for just a minute, let's stay with Alzheimer's. So what is Alzheimer's? It is a brain disease that causes problems with memory, thinking, and behavior, and symptoms eventually grow severe enough to interfere with daily tasks. It is a progressive disease where the symptoms gradually worsen over a number of years. So for instance, with my mom, I shared with you, she was on this journey for around 10 years. I think right now they say the average lifespan of a person with Alzheimer's is 8 to 10 years. And you see a lot of variability within that, but that is pretty typical. And then we do know that Alzheimer's disease is fatal. So what happens over time is it's just literally killing brain cells in different parts of the brain. And then when we get into late stage, not only is that person totally debilitated, my mom was full care. She could do nothing for herself, including she couldn't walk. She, wasn't even able to feed herself. Someone had to feed her. And so late stage, what's happening is the brain is no longer able to control our heart function and our breathing. And eventually Alzheimer's disease does kill us. I like this because I think it's a really helpful graphic. We talked earlier about how my folks, you looked at that picture, you don't look at mom and say, oh yeah, she has Alzheimer's. She just looks like a nice old lady. But she was very advanced in her dementia journey. And so I like this photograph because it helps you to understand on the left side is a healthy brain. And on the right side is an Alzheimer's brain. So you can see there are actually changes in structure and color and size. And what's happening in the Alzheimer's brain is that there is this abnormal buildup of protein. It's a naturally occurring protein. We all have proteins all throughout our body. But for some reason, in the Alzheimer's brain, these proteins start to build up. Normally, the body would use them and then flush it out. But for some reason, in Alzheimer's brain, that's not happening. And so what happens then is these cells start to clump together and then they die. And so the brain connections that we need to do literally everything in a day are being lost. And typically with Alzheimer's, the first thing we see is memory loss. That kind of makes sense? Yeah. Okay, so let's talk briefly. How am I doing on time, by the way? Okay. I get wound up. I can talk a long time. You'll have to tell me when to zip it. So the first thing that we often see is the memory loss that disrupts daily life. And so it's not, people will often dismiss it. Oh, grandma repeats herself over and over again. And it's so cute. It's so funny. Well, it ain't funny. It's probably dementia. It also gets really annoying if you're the primary caregiver and you're listening to these same stories 18 times a day. And that's exactly what happened with my mom. I remember so distinctly, she had surgery. And after that surgery, I remember having lunch with her. And we had noticed that her memory was not what it used to be, but we also thought it was directly related to the anesthesia. And it probably was at first, but then over time, we realized it wasn't getting better. And then she reached a point where she was not aware of her memory loss, but we sure were. And so we had lunch together one day and she literally repeated herself the same story 15 times in about an hour when I was with her. And I was like, yeah, that ain't normal. That is not okay. And so that was really the first time I knew something was wrong. But it's so much more than memory loss. And that's why I like this slide, because I think so often as caregivers, we don't understand all that's involved and that we are trying to get them to navigate our world like they always have, and they no longer have the capacity. So we know that there are challenges in planning and problem solving, and that can manifest, for instance, in someone whose electricity gets turned off. Well, it turns out they're not able to handle their mail. They're not able to balance their checkbook and do the things that are so simple for them. I also like to bring to your attention that these are things that represent changes. So, if you have somebody who was never any good at balancing their checkbook, you don't worry so much about them. But if you have somebody who is an accountant and they can't pay their bills anymore, that's a bigger red flag. So look at these things in the context of change. Difficulty completing familiar tasks. For my family, it manifested with my mom. She was a homemaker. She took care of our family forever and ever. And things around the house, like maybe laundry, forgetting to put in soap or putting the dirty clothes in the dryer instead of the washing machine, things like that. And so clearly, too, she was doing the best she could. She was trying to do the right things. Her brain just didn't know how to direct her. any longer. And I also like to say here, do not be worried if you've ever done this, because who in this room has not forgotten laundry detergent once or twice? I know I have. I absolutely have. And also, like, who has not forgotten to pay a bill, or who has not mislaid a bill? It comes in the mail and then you're like, where did I put that? You know, and it turns out maybe you threw it in the trash by accident or whatever. So we all have these kind of brain blips in a day. So don't worry, but look at these things in the right context. Confusion with time or place. I heard one time on the radio years ago, and they were laughing because there was something in the news about this man who had, gotten in his car to go check the mail. He must have lived in a rural area, and so he was driving, to the end of his road to check his mailbox, and he ended up in another state. And so, of course, they're laughing, and I get it. And my first thought was, that guy had dementia. That wasn't funny. That was a person who got lost, who was confused with time and place, and something was very wrong. But I can see how, to the general public, that just sounds kind of goofy and funny. Trouble understanding visual images and spatial relationships. So we know that our peripheral vision narrows as we get older, but a person with Alzheimer's, it may slow or start to, I've lost my words. That happens with dementia also. So there's a point where a person with Alzheimer's may actually have what we call binocular vision. So do this with me. So your resident with Alzheimer's who is sitting at the dining table, and they're looking at their neighbor, and then they're like, look, I like that coffee. I like that chocolate cake, but it's actually on her tray. But they don't know it. They don't see it because they literally don't even see what's in front of them. We can also see this manifest. We know that sometimes dark images, or for instance, up here on this mat, if there was a black or brown mat, floor mat in front of this door, a person with Alzheimer's might look at that and think it's a hole. And so instead of exiting this door, they're going to come back here to this other door. They're not stupid. Again, they're doing the best they can. They're trying to make sense of their environment. So that's what they're going to do, because they're not going to walk in a hole. I mean, nobody wants to walk in a hole, right? New problems with words or speaking, kind of like with what I just had. If you ask a person with Alzheimer's, what are these? They might describe them. They might have a hard time just saying glasses or eyeglasses, but they might say, well, you put them on your face, or they help you see. And so they would also try, again, because they're not stupid, they're going to try really hard to do what you're asking them to do. But that simple word finding ability is becoming more challenging for them. Misplacing things and losing the ability to retrace steps. There's no one in this room that has not done that at some point, but we're usually able to stop. Like if I lost my keys and I know I just walked in the door 2 minutes ago, I can retrace my steps. I can go back and look at my door and say, oh, I left them hanging in the door. I laid them down when I went to check on the dog. But there's all these things that we're able to do and backtrack and make sense that a person with Alzheimer's probably can't do. Decreased or poor judgment. This is one of my favorites. The example I have of this one is a client we used to have, and mom had Alzheimer's, lived out in Parker County in kind of a rural area, lived by herself. And the daughter went to visit her mom one day, and on the dining table, mom had purchased a side of beef. Do you know what a side of beef is? It's pretty much half a cow. And so, like, you need a deep freeze to put the beef in. Like mom had no need for a side of beef, no place to store the side of beef. But in that moment that she purchased it, it made sense to her. So I think that's a wonderful example of poor judgment. And we see this manifest in a lot of the different types of dementia. Then we also know withdrawal from work and social activities. With my mom, I grew up in the Church of Christ. You go to church 3 times a week. You go to ladies' Bible class. There's all sorts of stuff going on at the church, and my mom was withdrawing from those activities. And so that was a red flag for us. And then sometimes we can see changes in mood and personality. Do we have any questions thus far? I know I'm giving you a lot of information. Yes.
What evidence is there of genetics?
Yeah. So that's a great question. So her question is around genetics. And we know that the single greatest risk factor for developing Alzheimer's is simply age. The older we get, the more likely we are to have Alzheimer's. So then if we back it up and talk about genetics for a minute, there is a type of Alzheimer's that we see that tends to affect people early in life. In fact, there's even a whole village, I think it's in Colombia, and some of you may have seen on, I think CBS has run this story multiple times and then updates it over the years, but pretty much everybody in that village develops Alzheimer's, and they develop it at a younger age. And that is related to a genetic mutation. We also know that there are people who have a strong history of it in their family. So it's not specifically a genetic mutation, but if a person has a first-degree relative, meaning a parent or a sibling, they're higher risk. And so, for instance, I have a client that I was with just yesterday, and I think his mother, as well as so far 2 of his 5 brothers also have Alzheimer's. So there is obviously a hereditary component within this family, but it's different from the genetic mutation. So bottom line is genetics don't tell the whole story. And whether it is, no matter what may be at the root or causing the Alzheimer's, the thing that we say that we know to tell people right now is just healthy lifestyle. Yeah, because what if we could either, we may someday be able to say literally that we can prevent Alzheimer's, but even if we can't, what if we can at least delay, cognitive decline, even by a couple of years? That means that we get to hold the grandbaby. That means that we walk our daughter down the aisle. Those really significant family and life events. All right, so the stages of Alzheimer's, if you've been in this business for any length of time, you know that back in the day, they used to talk about the 7 stages. And more recently, I've noticed that the language that we use is mild, moderate, and severe. I think some of that is because people never fit cleanly into any one stage. And so this is, I think, also what you'll hear with doctors, but sometimes I'll talk to people and they're saying, well, my loved one is in stage 6. So usually when they say that, I just ask them, well, tell me what your loved one is doing. Help me understand where they are, what their deficits are, and what they're still capable of. They'll also see, and I should have spelled this out, but that MCI, that stands for mild cognitive impairment. And so a person with mild cognitive impairment has memory loss that's severe enough to be obvious to themselves and to others, but they're still able to function well in their environment. And some people, you can have MCI due to Alzheimer's, but you can also have MCI that never seems to develop any further. So it's obvious, the person has the memory loss, it's an unusual memory loss, but then they never seem to go on to actually develop true dementia. And don't ask me why. I don't know that we know, but there are people that just tend to stay in that same place. And so you can actually see it outside of Alzheimer's. So the steps for getting a diagnosis, if you are helping a family, maybe their loved one has been with you for a while and y'all are starting to see cognitive decline. So we recommend at the Alzheimer's Association, best practice is to get them into the doctor as soon as possible and to have a thorough workup. And part of what physicians are doing is it's a process of elimination. They want to make sure it's not something else. And so they should do a thorough history and physical. They should do blood tests. They should do a urine test because remember, the UTI can look like Alzheimer's. So we want to make sure there's not something else going on with them. We want to assess for depression because again, depression can mimic dementia. We also typically, a physician will order an MRI. The MRIs just help to kind of identify if there's something else going on. So they're not going to show specifically Alzheimer's because the Alzheimer's is happening at a microscopic level, but the MRI can show if there's some shrinkage or possibly a tumor or cancer or something else going on with the individual. So that is often used. The PET scans are more refined, but sometimes it's hard to get Medicare or insurance to pay for them. But the PET scans can actually help us to identify the proteins that are building up in the brain that we associate with Alzheimer's. So, I feel like everybody's journey is a little bit different in terms of getting a diagnosis. Some of it just has to do with their access to healthcare, related not just to what's in their community, but also their coverage. For instance, if they're on Medicare versus a private insurance. And then the one here in the middle is a cognitive screening, and that one is really helpful. And there are clinicians, they're called neuropsychologists, and they help identify, especially if a person has been deemed to have dementia, it can be really helpful to tease out which type of dementia. So they look at a variety of things related to brain function and can often come back and say, yes, I believe this person has dementia of whatever type. So maybe it's not Alzheimer's, but it's related to Lewy body or frontotemporal, something like that. So the benefits of early diagnosis, we touched on this earlier, but to get the legal and financial planning done, because these individuals are not, if you don't do it early, they're not able to make decisions for themselves. Like if you took a person with mid-stage dementia to an attorney, technically the attorney shouldn't execute those documents because that person doesn't have the capacity to make decisions. It also gives us a chance to build a care team. So, a lot of times the care team is above and beyond just the family. Maybe, it involves a friend from church or a neighbor or multiple people, even folks in the doctor's office. You can't just call up a doctor's office and talk to the doctor usually, but maybe there's that key person, there's a gatekeeper in the office that's going to be really helpful on the journey. It also, this early diagnosis gives us time to talk with our loved ones about driving, about housing options, about what do you want when you're no longer able to communicate with me about your wishes. What should I know? What should I do? Do I have permission to take the keys away when you reach point XYZ? So it's valuable to have those conversations. And then the last thing is we know that the medications that we have in the market right now are most beneficial for people who are in the early stages of Alzheimer's. These are FDA approved treatments. I'm sure you have seen some of these names, and I did not list, but there are even some now that are used to help treat some of the behavioral symptoms of Alzheimer's. So those at the top are names that have been around for a long time. Those meds, I think all of them are 20 or more years old. Nimzeric is one that was approved a few years ago, and it's just a combination of donepezil and memantine. But what's exciting is those medications in the past, they did not treat, stay with me for just a sec, they did not treat the disease, they treated symptoms. So think of it this way. If you take an arthritis medication for pain, it's not really treating the arthritis, it's treating the pain, it's treating the symptom. And so the new medications, Leqembi and Kisunla, they're infusions, they're actually able to go into the body, they cross the blood-brain barrier, go into the brain, and they help to clear out those proteins that are building up in Alzheimer's brain. And so they are treating the Alzheimer's, not just symptoms. And so for many people, not all, but for many people, we see an improvement in their condition. And that's what we're looking for. So the hope is maybe at some point we can start backing these medications up. Maybe we can start having people who we know are high risk, who we've already identified have the risk factors. Maybe we found through PET scan this buildup of protein in the brain, and they can start taking the medication prior to the onset of symptoms. So that's part of what our focus is going to be in the future. So we're really excited, and I believe related to Leqembi and Kisunla, there are more than 100 other medications in the pipeline that are working in the same way. And the nice thing is it seems like each one that comes out tends to be a little more effective. The prices are going down. So there's still a lot of barriers, truthfully, to people getting what they need, but we're making real strides. So this is the first time that we can legitimately say we can treat Alzheimer's, and we're excited about that. So I would encourage you, if you want to learn more about the different treatments, to go to our website is alz.org/treatments. And so you're going to find information on those older meds as well as the new ones. But I find this to be really, really interesting. So let's talk just for a minute about managing behaviors, because I think that's so often, like when I talk to property managers, leadership that are within properties, they just want to know, how do I manage these difficult situations? How do I manage people? And so a lot of it, I think, is just working very closely with staff to help them understand, first of all, the deficits that the person with dementia has. Because like I said, we keep trying to get them, like everything in their world is changing, and they're literally in the same space that we are, but they do not think, feel, hear, or see things the way we do. We can be standing in the same room, and they're not experiencing their environment in the same way, but we haven't learned often how to change how we relate to them and how we engage with them. So if you can help your staff to better understand those deficits and how to meet them where they are, then you're going to see a greater quality of life for everyone. And we want staff to have a greater quality of life because they're going to do a better job. They're going to take better care of other people too, and possibly themselves. But also that resident is going to fare better, and then the family are going to feel better about the experience. So we want to understand the deficits. We need to learn to change our communication style, and we'll go into a little more detail on that. And one of the things I love, so as long as I've been with the association, it's been just hit my 18-year anniversary. And the very first program that I ever worked on, we had brought in a speaker from California, and she had one of her sessions at a seminar was titled, "He Ain't Misbehaving, He's Communicating." And so what it helped to understand is that when they're acting in ways we don't understand, or that are potentially harmful to them or to others, or just frankly annoying, and it's okay to admit that a lot of the stuff they do is incredibly annoying, maybe not harmful, that maybe what they're trying to do is express, instead of looking at it as a behavior, because the behavior is something that we look at and think, oh, that needs to be corrected. Behavior is a term that we use with children. We know we don't want to treat them like children. We know we want to treat them like the adults that they are. We want to show respect to them. And so let's look at what we see them doing as an unmet need as opposed to a quote, quote, behavior. Now we still use, I mean, if you go on our website, you're going to find tons and tons of information about behaviors and references to behaviors. But if you can, in your mind, kind of flip-flop it, and you'll even hear me say it again, but to really look at what's going on with them as an unmet need, that can be incredibly helpful. So one thing we suggest is that you assess their needs. What is it that they're trying to communicate? Is there something in the environment that is making them uncomfortable? Is it something physically inside of them, of their body? You know, a lot of research has been done around pain in dementia, and we know that pain often goes untreated in people with dementia because they're not going to come up to me and say, hey, by the way, I'm in pain. You need to medicate me. My mom, I think, is a great example of that. My mom had arthritis and she was in, I think, actually, at least one of her hips and knees, she was bone on bone. Now, if I went up to her and said, Mom, are you in pain? She would have told me no. But if I went up to her and said, Mom, and I knew where it was, like, Mom, are you sore? You know, how are you feeling? I would sometimes even touch her hip or her knee, and she would say yes. And so then I knew that it was time to medicate. And then sometimes, I mean, ideally, gosh, what if we could actually help them avoid being in pain and, you know, be giving medications? And I know you'll have a lot of requirements and regulations around when and how medications are given. We don't want to over medicate, but and if we could help keep that at bay, they would feel so much better. And we would too, because then they may not be acting in ways that we don't understand because they just don't have the ability to communicate with us in the same way that they did. Another thing that we know is just don't argue. And here's where I think we really miss the boat as caregivers, as we so often are talking to them about, you know, they come up and they ask us a question and we're trying to tell them, we're trying to set them straight, whether it's that, you know, they can't find a spouse who is deceased, or if they're confused about what day of the week it is. You know, my mom, growing up in Church of Christ, she got to where Wednesday for us was prayer meeting. Well, as her dementia progressed, every day was prayer meeting. And so she would get kind of agitated in the afternoon. She was ready to go to prayer meeting. Well, me standing there trying to tell her, even if I'm doing it in good faith, even if I'm just trying to explain to her, Mom, today's not Wednesday, it's Friday, it feels like arguing. So we are doing our best to meet their needs, but all we're doing is agitating them more. So I think for us to learn to not argue, to not even try to reason with them, because they feel invalidated. So another thing that I recommend is just learn to say, I'm sorry. You know, if they think their purse, I used to have a resident who lived in assisted living when I managed it, and she literally called the police multiple times. She called them and asked them to dust her prints because her red purse and red shoes were missing. Well, she was hiding them. And so we could usually go into her room or her apartment and find them. But she called the police and they would, you know, like show up on our door, and they finally figured out, oh, this lady has dementia. But instead of me trying to explain to her that, you know, that didn't happen and that, by the way, you're stupid and you're the one who hid them, man, I'm so sorry. How about, can I come to your room and maybe we can look together and just validate? Because think of how we feel in the moment. If we're having a bad day, sometimes we want to help to find a solution. But a lot of times we just want to be validated. So how would we think that a person with dementia is any different? And we don't even have to admit, you know, like if they think things are stolen, we don't have to say, well, yeah, you're right, it was stolen. I mean, we don't have to play into that. We can just meet them where they are, validate, and then try to redirect. So these are some of the things that we often see in dementia communities, especially if you have a lot of people who are living together that have dementia. I think you can start to see increases in some of this quote, quote, behavior. And there's not always things we can do about these other than just, again, to meet them where they are, to try to, if they're in an environment that's uncomfortable for them, can we remove them from that environment? Can we lower the volume on the TV or get them to a place where maybe they're going to sit and drink coffee, or just do things to validate and redirect, try to get them on a different track, because, you know, they get stuck and they say the same things over and over again, or they do the same things over and over again. So to try to move them past where they are stuck can be a good thing. We know sometimes, I'm sure all of you are familiar with the term sundowning. Yeah, and that is a real phenomenon. Interestingly, you know, we usually think of it in the context of happening in like afternoon, evening, but I even knew of a lady, she had been a night nurse in a hospital. And so when she moved to assisted living, around midnight, she would start to get agitated and busy. And the staff figured out, oh, we just let her give reports. If you just sit down, give her an empty chart, even a full chart, because she's not going to know what it says. I mean, it's not like she's going to be able to report out later that, Ms. Smith had consultation that day, but, just to meet them where they are, let her give a report, talk to her, and then go tuck her in. And they had struggled for a while with this, and she was going up and down the halls, knocking on other doors because she was making rounds. She was doing what she was supposed to. So to just figure out where they're coming from. And sometimes it's not that hard. Another thing I realize, this is not related to sundowning, but like with my mom, she went through a period where she would sit on the couch and there was a pretty vase of flowers sitting on top of the TV table. And so she was looking at that. And she would tell me 80 times a day how pretty those flowers were. Oh, you're not getting on my nerves. All I had to do was move the flowers so she couldn't see them, Not that I was trying to remove something pleasant from her environment, but sometimes we just bang our heads against a wall when we're working with people with dementia, and the answers are so simple. But we have to take a minute and just think about what are their needs, what can we do to meet their needs, and make sure that they're safe as well as other people. Okay, so I want to talk about this just for a minute. So like I said, we never argue. Instead, we agree. I'm going to say agree/validate. Don't ever try to reason with them. And I'm going to say there are times, maybe like if a person is earlier stage, there may be times when you try to tell them, I'm going to say the truth or, give them more information. But over time, it's just not going to do much, if any, good. We don't ever want to shame them. We want to distract. We don't want to lecture. We want to reassure. And try to stay away from the word remember. Don't you remember? Don't you remember you just had lunch? Don't you remember that your daughter left here 5 minutes ago? And that's, I think some of the things that I'm talking about are counterintuitive. So we have to learn over time to change the way we do things. I think as caregivers, care partners, we have to learn to give ourselves some grace. I mean, people who are caring for loved ones with dementia really beat themselves up a lot. And that's not productive. But to learn to kind of change the way we interact with them over time. It's a learning process for us. And sadly, I always say dementia is a moving target, because just when you have it figured out, they're going to change. All right. So things that you can take advantage of, as well as the family members or the people that you're serving and working with. Our 24/7 helpline is the best tool in the toolbox. You can call this number any time of the day or night. So if you simply, and the great thing is, again, it's national. So I know you're here from across the state, or at least this area. And so you can call this number yourself. You can get information on upcoming education programs. You can get information on support groups in the area. But people who call this number can also get a consultation. So the way this works is that they almost like triage the calls. So sometimes if it's just a simple thing that a person needs, maybe even they're trying to find a physician in their area, the people who staff this line have access to a national database. And so even if you're looking for a resource in Seattle, Washington, they can pull information up. It's at their fingertips. But then if the person calling needs a deeper level of care and support, they can talk to a care consultant. Those care consultants are master's level social workers and counselors who really provide a lot of support. And it's very much person-centered. We talk so much about person-centered care in our business, and that, we're meaning how do we care for the residents, the clients, the patients. But our care consultations are really focused on the professionals and on the family caregivers, and they provide person-centered care for those individuals. And sometimes what they're needing is to help problem solve a very specific issue. Maybe Ms. Jones has stopped urinating in the toilet and is now urinating in the kitchen sink. The first thing we do is that we celebrate that she's at least urinating in a receptacle that can be easily cleaned. And then we try to problem solve that a little bit. So some people call this a hotline. It's not, I prefer not to use that term because a hotline implies that it's just for crisis. It's not. Now, we do get crisis calls sometimes, but we also just get people who are in that moment. And I really love this number because it's around the clock. Because when my dad was taking care of mom at home and she was urinating, you know, having incontinence episodes throughout the night, sometimes he just needed to talk to somebody at 3 a.m. He didn't need to have to wait till the next day, you know, or if you're cooking the turkey and mama always cooked the turkey and you can't figure out how to do it, maybe you have a meltdown on Thanksgiving Day and it's okay to call the helpline. We also have free education all throughout our community. We have an e-learning portal that you can access on demand. And then you can also utilize our community resource finder if you're looking for local services. Also, there is on that page, you can go up, I think it's in the right-hand corner as a provider, you can click on that and you can set up your own profile. So if your community is not listed in Community Resource Finder, then you can set it up. So I'm going to stop